So hi everyone, welcome to this lecture on antimicrobial resistance across health and social care settings. I'm Laura Shallcross, I'm Professor of Public Health and based at the Institute of Health Informatics at UCL. So just to start with the learning objectives, so what we're aiming to get out of this session is to think about the different patient groups that access the health and social care system, and focusing particularly on primary care, secondary care, and care homes for older adults. And then to think a bit about the people who access those services and therefore what the priority drivers of AMR are in those different settings. And then to think about why that translates into the need for different approaches to tackle AMR in primary care, secondary care, and care homes. I've included a list of optional pre-reading for you here, and so this is data from primary care, an example from the UKHSA, UK Health Security Agency surveillance programme, and also an example from care homes. So do with that what you will. So just to go right back to the beginning, as many of you will know, one of the main reasons why it's so difficult to tackle the problem of antimicrobial resistance is its complexity. So in this lecture, I'm going to focus on human health, but we know very clearly that AMR is a One Health issue, by which we mean it affects people, it affects animals, it affects the environment. And so whilst here we're focusing on the problems in humans, it's really important to recognise that this sits in a much bigger programme of activity, which is all about trying to think how we can work across all these different settings to try and tackle the problem of antimicrobial resistance. But today what we're going to focus on is the relationship between antibiotic use and AMR. And that's because we know very clearly that there is a strong relationship between the amount of antibiotics that get prescribed and the levels of resistance that we see in people. And we see that relationship both at ecological level, by which I mean country level. This graph on the left here shows the risk of resistance in different countries, so each dot represents a country, and you can see that the risk of resistance increases with the antibiotic sales. So the more antibiotics that a country uses, the higher the risk of resistance in its population. We can see here in the Netherlands, bottom left-hand corner, have the lowest rates, Spain highest rates. This is data from some years ago now. But we also see that relationship between prescribing and resistance at an individual level too. And so on the right-hand side of the slide, this is data from primary care that's looking at the risk of resistance in patients in the period after they've been given an antibiotic. And what we can clearly see is the risk of resistance is greater in the period shortly after you've had antibiotics, and it decays over time. So very good evidence that prescribing drives resistance in people. So then the next logical step is to think, well, okay, so one way of tackling antimicrobial resistance is to try and reduce the amount of antibiotics that we use. Makes sense. And so then the question is, well, where does prescribing take place? Where should we focus our efforts? And so this is data from the UK Health Security Agency looking at where the prescribing happens for humans. And we can see the majority of prescribing is in the community, in primary care, general practice. And then we can also see the breakdown in other settings. So around 13% for hospital inpatients, 7% for outpatients, and some prescribing in dental and other community settings. But if you're going to have the maximum impact here, you would logically say, let's focus our efforts on primary care, at least to start with. So we know that there are strong incentives to try and optimise antimicrobial use across health and social care, but it's not quite that simple because it's not like patients just sit in one place. We know that patients move across settings, so people go to primary care, they also go to hospitals, people in care homes see their GP. And so we've also got this additional problem that infections can move and we can import and export infections between different settings. And so this was illustrated really well by the COVID-19 pandemic, where we had all sorts of problems with people in hospital being discharged back into care homes and the risk that infections were spreading and AMR was spreading in that way. And so when we try and think about this, we really need to consider the different groups of people that are accessing these different health and social care settings, But we also need to think more broadly about what's going on in these different places. So, for example, the workforce is very different in primary care, in hospitals, in care homes. The environment is very different. In a hospital, we know you've got lots of beds, you've got lots of nursing staff. Well, in a care home, it's people's homes. And so we've got to think about all of those things when we're thinking about the problem of AMR and how we might tackle it. And this really then brings us on to the idea that what drives AMR in these different settings is likely to be different, and therefore the way that we try and tackle this problem needs to be nuanced in different ways across primary care, secondary care, and care homes. So starting off with primary care, well, what does that mean? What is that context like? So pretty much everybody in the UK can access primary care, probably will access primary care at some point. There are about 300 million patient consultations per year, and the kinds of patients who go and see their GP tend to have mild or moderate severity infections. If people are seriously unwell, they don't tend to go and see their GP, they go straight to hospital. So then thinking about who the key populations are for antimicrobial resistance, well, lots of children get seen in primary care, they get a lot of antibiotics, but also there are other patient groups, particularly those with comorbidities. So by that, I mean people who have chronic illnesses that mean that they require more antibiotics because they get infections regularly. And the classic example here is people with chronic obstructive pulmonary disease. So they very often get respiratory symptoms and often get prescribed antibiotics to try and make sure that that doesn't become severe and then require a hospital admission. And then if we think a bit about who works in these settings, well, the main givers of care are the GPs themselves, so doctors, but also practice nurses, and they can also prescribe in some settings. If we think about secondary care, well, again, pretty much everybody can visit hospital. Not all of us do. And the number of visits to A&E is therefore substantially less than the number of visits to see the GP, around 23 million a year. There are around 7 million hospital admissions, and the patients that tend to go to A&E or go into hospital will usually present with moderate to severe illnesses. So you're unlikely to go there if you've just got a bit of a cough or a cold. You certainly shouldn't. But then thinking about antimicrobial resistance, so again, our key populations here are slightly different because we're looking at more severe illness. It tends to be people who have impaired immunity, they're immunocompromised, so particularly patients with diseases like cancer, people who are having organ transplants, they often have treatments that suppress their immune system, and that means they're much more at risk of infections and antimicrobial resistance. And again, these groups of patients with chronic illnesses, with comorbidities. So COPD, I've just mentioned, but another example would be people who have renal disease, renal failure. They're much more at risk if they get urinary tract infections. And again, the consequences of repeat antibiotic exposure with antimicrobial resistance. Thinking about who works in these settings, so it's different again. We have doctors, but we have doctors across the spectrum of seniority, right from those who've been on the wards for 2 days, the junior doctors, through to highly experienced consultants who may specialise in infection and so are very, very experienced in knowing how to treat patients with infection and antimicrobial resistance. We also have nurses, healthcare assistants, and allied health professionals, and all of those individuals play a key role, not just in treating infections, but also in preventing them. And then thinking about social care, again, totally different population. So if we're thinking about care homes for older adults, well, these tend to be people who are at very advanced age, maybe an average age of 85 years, and people who have disabilities. And there's a very wide spectrum of need here, which varies from people who receive care in their own homes through to people in residential care. And so that means people who are living in an environment where they get support, but they don't have medical needs, through to nursing homes where you will actually have nurses on site because people have medical needs in addition to care needs. And around 800,000 people receive long-term social care. When we're thinking about antimicrobial resistance, it's similar again. We have those people who are immunocompromised, but we also have a very large population of people who are vulnerable and have lots of coexisting illnesses. And so, unsurprisingly, they are very vulnerable to infections and antimicrobial resistance. When we think about the workforce in this setting, well, it's quite different because the primary workforce are carers, and usually they've not had any healthcare training. And so when asking people to think about infections and antimicrobial resistance in this setting, it's arguably asking quite a lot from people who haven't had training in healthcare. In some care homes, there will be nurses in the nursing homes, and care is also delivered in these settings by GPs who may come in person or via remote consultations, and also from geriatricians, so specialists in secondary care and the care for older adults who then come into the care home to provide more tailored care for individuals. So that's just to kind of give you a quick overview of the different kinds of places in which infections and antimicrobial resistance manifest and the key differences between them. And now what I'm going to do is talk a bit about each of those settings and what the priority drivers of antimicrobial resistance are. So starting off with primary care, well, one of the key findings probably 10, 15 years ago when the National Action Plan on AMR was first being formulated, so the first version of this, was the observation that there's huge variation in antibiotic prescribing between general practices. And so this graph on the right shows each dot is a general practice. And this is prescribing for people with coughs and colds. So as most of you will know, coughs and colds are usually caused by viruses. And so really, people shouldn't be getting antibiotics for these. But then you can see the proportion of consultations where patients did receive an antibiotic. And this is quite old data, going back to 2011. But you can see that a very large proportion of people are getting antibiotics. But more importantly, there's huge variation. And so the idea here was that, well, if we see this amount of variation, there must be a lot of scope to improve. And so there's been a big focus on trying to reduce unnecessary antibiotic use in primary care. And there are lots of ways or lots of approaches that have been developed to try and facilitate that. So an example is for GPs to use scoring systems. So this would be when a patient comes in, you look at their symptoms, you look at things like the redness, their temperature, those kinds of features, so both in terms of the examination and in terms of the history, so talking to the patient. And then you have a score that helps you decide, does this person need an antibiotic now, yes or no? Another strategy that's been used very effectively, particularly for respiratory infections, is delayed prescribing. So what I mean by that is the patient comes in, they say, I have symptoms, and it's clear that they have an infection, but the GP isn't sufficiently worried about them to say, you need an antibiotic now. And instead they say, well, okay, let's watch and wait. If you get worse, come back, or maybe even give them the antibiotics, but say, don't take them for 24 hours or so, see how you get on. And that's another way of trying to reduce total exposure to unnecessary antibiotics. Other strategies that have been widely used are financial incentives and targets. And so we've had all sorts of different targets to try and support GPs to reduce the amount of antibiotic use in primary care. And this is also supported by training and toolkits. And I've given you some examples of some of the current approaches that are recommended. So that sounds relatively straightforward. Only give antibiotics to patients who need them. But the real challenge here is trying to know who does and doesn't warrant an antibiotic. And the key issue is that we don't have a reliable, quick diagnostic test for infection. When you go and see your GP, they can't just dipstick your urine or do a magic blood test and say, right, this person has infection, needs antibiotics, this person doesn't. We don't have access to those kind of diagnostics. And so instead, it's all about trying to assess risk and work out who does or doesn't need treatment. And so we did some work to try and think about which patients are most exposed to antibiotics and where we might focus our efforts. And again, this is data from several years ago, But what we found is that almost half of patients over a 3-year period going to primary care didn't get any antibiotics. But you can also see that there is a small group of people who get loads and get these sort of repeated exposure to antibiotics. And so that does really raise the question of where you might focus your efforts, and should this be about trying to reduce everybody's use of antibiotics, or should it really be about thinking who are those individuals who are getting lots and lots of antimicrobials, and how might we try and reduce their exposure, because there's quite a strong argument that they are most at risk of developing AMR. And so just thinking about that, what kinds of populations, well, you won't be surprised to hear that the patients who get the most antibiotics tend to be those with underlying health conditions who are frail and older. So patients with chronic obstructive pulmonary disease, for example. But we also see a group of patients who, at least according to the data, seem healthy. So there's no evidence that they have underlying chronic conditions, but they're still getting lots of antibiotics. And so there's still lots of work to do to try and understand which are these different patient groups and what kinds of interventions can we put in place to try and reduce their exposure to antibiotics, or their unnecessary exposure to antibiotics. And so that's all fine, this general idea that we're trying to reduce the use of antibiotics in primary care. But when these ideas were starting to be rolled out, there was quite a lot of concern that there could be unintended consequences, because of course some people genuinely need antibiotics because they have an infection, and it may get worse if they're not treated. And so there were worries that we might see increases in common infections like quinsy, things like pneumonia. So this is where people might present with a sore throat, they might present with respiratory symptoms, but they don't get an antibiotic, and it turns into these more severe manifestations. And so there's been some ongoing work to try and see whether this risk is true or not. And the good news is that so far it seems this is not the case. Overall, there is very strong evidence to support the use of delayed antibiotics, particularly for respiratory tract infections, for urinary tract infections, which are one of the other most common reasons people go to primary care. The data is much more complicated, and it looks like it's probably safe to withhold antibiotics for uncomplicated urine infections in young and healthy women, but the data for older adults is a lot less clear, and still major concerns about increasing the risk of hospital admissions and severe disease if you don't give those patients antibiotics promptly. So very briefly, where are we in terms of this idea and goal to try and reduce antibiotic use in primary care? And the news is pretty good. So since the antimicrobial resistance national action plans have been in place, we've seen steady decline in the amount of antibiotics that are being prescribed in primary care. You can see there was a particular dip during the COVID-19 pandemic because people weren't going to their GPs in the same way, and that's come back up. But overall, a reduction in the amount of antibiotics that are being used in primary care, but still more work to do. So then moving on to secondary care, well, I've already mentioned it's a very different population, so the patients are usually much sicker. And here, the big concern is always about sepsis. And so sepsis is a more severe manifestation of infection. So it's when infection gets into people's bloodstreams, and delaying treatment for sepsis has been very clearly documented as something that must be avoided, because people can become extremely unwell. But again, we have the challenge that when a patient comes into A&E, how do you know who does or doesn't have infection? And how do you know who does or doesn't need an antibiotic? Because we have this challenge that there is not this perfect test for infection. This is also compounded by the fact that in secondary care, people are under huge pressure in terms of workload. There's not a lot of time to review patients. And we don't have good data in secondary care to help the clinicians and teams of people who are trying to tackle AMR to know the best ways to try and reduce this problem. And so the strategy that's being used, mainly used in secondary care to try and tackle AMR, is something called Start Smart, Then Focus. And so this is the idea that you don't try and not give people antibiotics, like in primary care. You're not doing delayed prescribing, but instead you give them to people because you think they're sick. Let's get those antibiotics in. We don't want this to progress to sepsis. But then you review the patient and you stop antibiotics early in those patients where there's evidence that they don't need them, and you try and go from the kinds of antibiotics that are most likely to cause harm, so-called broad spectrum antibiotics, which treat lots of infections, different kinds of bugs at the same time, to narrow spectrum antibiotics where you're much more targeted. And this is all about trying to reduce the risk of antimicrobial resistance. So here the strategy is put people on antibiotics, but try and stop them as soon as possible. So thinking a bit about how antibiotics are used in secondary care, and this is a real challenge. Unlike primary care, where we've got pretty good data that tells us about antibiotic prescribing in relation to patients with infection, we don't have that data in secondary care. So electronic health records are starting to make this a bit easier, but the best data that we have is from the UK Health Security Agency surveillance reports, online data repositories such as Fingertips and the SBOW report, and the references for those data sources are at the end of this presentation. And that gives us some sense of how antibiotics are being used at hospital level, but it really doesn't go down into the granular detail that we would need to help people in those settings think about, this is what I should be doing here to try and reduce antimicrobial resistance. And so what we've been doing in my group at UCL is trying to think about how we can use individual level electronic health records to try and get a better understanding of how antibiotics are being used in hospital, so that we can give clinicians more better data and detailed information on what they might be able to do in their hospital to try and tackle the problem of AMR. And so this is quite a complicated picture, but what it shows is the two sources of information that we have to work with. So we have data on antibiotics that are administered to patients, and we also have data on antibiotic prescriptions. And so every time a drug is administered or prescribed, we have a record. It tells you the drug, it tells you the dose, it tells you if it's oral or intravenous, and it tells you when that prescription was issued or the drug was dispensed. And that's fine, but if you want to start being able to understand how antibiotics are being used and where the opportunities for improvement might be, you need to convert that into something that is actually meaningful. And so we've been doing some work both at University Hospital Birmingham and also locally at UCLH to try and use the electronic patient records to move towards that. And so here what we're trying to do is to understand the episodes of prescribing in patients. And so when a patient comes in, they might get a one-off medication. So that's the OOF here. They then might go on to a regular course of treatment, and they then may be given antibiotics to take away the TTA. And so that is a prescribing episode, and we need to be able to construct that in the data so that we understand that that's the process. But then the patient might come back. So say they got the wrong antibiotic, the infection comes back, they come back to the hospital and they go through a similar process and get more drugs. And so what we've been doing is working with the data so that we can understand that as an episode and relate it to the tests that people are getting and to treatments. And so starting to have a much more detailed understanding of which antibiotics people are getting and what happens to people with different conditions. And so that's allowed us to then start to put together for an individual patient, such as here, you can see when they were on different drugs, how many days they were on them for, and what their diagnoses were at different points in time. And so just trying to think about how we can manipulate the data to get a better understanding of how antibiotics are being used in secondary care. So this then brings us on to this idea of data-driven antimicrobial stewardship. So how we can use the data in electronic patient records to help us improve how antibiotics are being used in hospitals. And there are various different ways that we can do this. So one is a bit like the primary care example that I showed you. One is simply being able to measure how antibiotics are being used in different parts of the hospital and understand how it varies so that you can find outliers. You can say, well, why on this ward are they using double the amount of antibiotics compared to this ward? That might make sense, but maybe it doesn't. Let's go and investigate. Something else we're interested in doing is trying to measure the most useful things in different settings. So a challenge might be, we can tell people in your hospital you use a total amount of antibiotics. But if you're a doctor and you will think, well, I'd like to be better at this, that doesn't really help you. And so you need to have the right measurements for clinicians in different places in the hospital. So to try and give you an example of that, if you're a doctor who's working in the acute medicines unit or in the emergency department, then you probably see quite a lot of people with community-acquired pneumonia. And so what might be most useful there is understanding what are patients with community-acquired pneumonia being treated with. Is that being done correctly? Are there opportunities for improvement? Whereas if you're a doctor who's working with patients who have cancer, well, we know those patients get lots and lots of antibiotics because they get lots of infections. And so there, it's arguably more useful to know all about the antibiotics that that person has had in the past and which antibiotics might be most effective for them in the future. So just trying to tailor the information so that it's maximally useful across different parts of the hospital. Another strategy we've been exploring is thinking about how we can change organisational awareness of AMR and antimicrobial stewardship. And as we all know, if you want to effect change in a hospital, there are different levels at which you need to try and do that. You can talk to the clinicians, but you also need the bosses in the hospital to be supportive of that. And so we've been looking at how we can use this data to help people understand the problems of AMR at board level. And then finally, clinical decision support systems. So we've developed a tool at UCL called Samurai. There are other tools. Imperial have developed a tool called Epic IMPOC. And these are all about using the data to try and provide information to clinicians who are seeing patients to try and help them make better prescribing decisions and reduce patients' risk of AMR. So with the first of these, this picture just illustrates some work that we did looking at antibiotic use across different wards and specialties in the hospital. So you can see cardiology, general medicine, and so forth. Each dot is a consultant team. And here we're looking at the time from patients being started on intravenous antibiotics, how long it takes them to be switched to oral. So switching from IV to oral is good practice, it's what we want to see, but we can see across these teams that there's quite a lot of variation in how long that takes. And so that might be right, but it also suggests that this is an approach that could be used to try and work out where are opportunities to improve how antibiotics are being used. This is a view of a mocked-up dashboard, and here what we're trying to do is take the data that's in the patient record and then think about how we can display it to clinicians to help them understand whether their patient does or doesn't need to be receiving antibiotics. So all this information is in there, but it's just about trying to show it in a way that makes it as accessible and as easy for the clinicians to use. And then we have our project called Samurai, and this is all about trying to help doctors work out of those patients who are on antibiotics who can stop them early. And so the idea here is that in an average hospital, you have around 550 beds. But of those beds, around 185, so around a third of patients in those beds are taking antibiotics. So a huge amount of patients taking antibiotics. But we also know that around a third of those people on antibiotics probably don't need them. They either don't need to be on them at all, or they would benefit from being switched to an oral antibiotic or a different kind of antibiotic. But then we know that in a hospital, you've got an average of around 3.5 specialists in infection who are really good at working out who does or doesn't need to be on antibiotics. And so the idea behind Samurai is trying to make this process more efficient. It's saying we know there are all these people taking antibiotics, we know some of them don't need them, how do we find them? We can't magic more doctors, but can we develop a machine learning algorithm that can monitor patients who are taking antibiotics and say, if you've only got 10 people to see today, these are the top 10 people that you should go and review. And so we did a pilot study where we worked with the clinicians to use the data that they had already collected on the decisions they made about who did or didn't need antibiotics. We then linked that to the electronic health records and were able to develop a machine learning algorithm to predict which patients would benefit most from being reviewed. And we then tested out how well that worked by essentially using the algorithm on a random sample of patients in a hospital, seeing what the algorithm said, and then sending the clinician to review the patient, and did they agree? And so the take home there is that we found that the algorithm worked better than chance, but the real challenge here is thinking about how you then operationalize that and start putting algorithms into clinical practice. And so we're doing more work now to see whether this model might actually be feasible to invest more effort in trying to use it in UCLH. So then finally moving on to care homes and the challenges and priorities around antimicrobial resistance in this setting. And this is really a very, very different context. So the first thing to say is that we're dealing with care home residents. They're not patients, so they're not acutely unwell. They're very vulnerable, and there are other challenges with this population, such as high levels of dementia, cognitive impairment, and other disabilities. So when you're thinking about infections and antimicrobial resistance, you have to have quite a different perspective on it. So whereas in primary care and secondary care, the priority is always, let's treat the infection, we want the person to get better. In care homes, sometimes the question is, does it actually make sense to send this patient into hospital? They're on end-of-life care, they don't want to die in hospital, maybe we don't treat the infection. So very different considerations here. A further challenge is I've already mentioned how difficult it can be to work out who does or doesn't have an infection. Well, in this population, it's even harder because older adults often don't have typical symptoms of infection. The symptoms may be absent entirely or atypical. And so trying to understand who does and doesn't have an infection is really very challenging. And so for those reasons, in contrast to primary care and secondary care, I think the focus here really has to be about preventing infection. It's important in those other settings too, but in care homes, infection prevention is arguably where we should be focusing the majority of our efforts. So thinking about which infections are important in care homes, well, I've already mentioned about the challenges that we have around the lack of data in secondary care. It's even worse in this setting. We have almost no data on what's going on in care homes, and that's partly because we don't have a national registry of care home residents. So if tomorrow you said, I want to know exactly how many people are in a care home today in the UK, we can't do that. We don't have those estimates. There's also no surveillance, so systematic surveillance for infection in care homes at all. This was something that really came to the fore in the COVID-19 pandemic. We have systems to monitor infections in the community, in hospitals, but we don't have this for vulnerable people in care homes. But the good news is that because of the pandemic, there have been some advances in the data and the research infrastructure that exists as a direct result of the pandemic, and the Vivaldi study that I lead is an example of that. So I've said all the things that we don't know, so then on to, well, what do we know? And so we know that there are very high rates of antibiotic prescribing in care homes compared to people of comparable age in the community, so lots of exposure to antibiotics. We also know that residents have much higher rates of infection and much higher rates of antimicrobial resistant infections compared to people in the community of similar age. We also know that one of the most common infections in care homes, urinary tract infections, is the leading cause of drug-resistant bloodstream infections. And so there's a real need to try and reduce community onset UTIs as a strategy to tackle the problem of antimicrobial resistance. And so A lot could be gained from trying to prevent infections in this setting, not just in terms of preventing antimicrobial resistance, but also in terms of helping the health and social care system to work more effectively, because if residents are in the home and not going into hospital, that benefits everybody in the NHS too. But there are lots of reasons why trying to prevent infections in care homes is difficult. So first up, well, care homes are not mini hospitals. They're very heterogeneous. It's not like the NHS, where we have the NHS umbrella and the hospitals that sit under it. Care homes are run by different private companies. We have the challenge that residents often have cognitive impairment. So if you have somebody with infection, say they have a respiratory infection or you have a flu outbreak and you want them to not spread the infection, you can ask them to stay in their room, but they probably won't, and it's very difficult to manage that. We also have the challenge that, unlike hospitals, there isn't that in-house expertise from the nursing staff, infection prevention and control, or it can be very limited. It's good in some places. And that the models for delivering infection prevention control are very variable across the country. We also have the challenge that there's huge uncertainty about what works to prevent infection in this setting. So we know that most of the evidence comes from healthcare settings, and they are very different to care homes, as I hope I've convinced you. And there's not a lot of research that directly comes from this setting. There's not that culture of research in care homes. And often the key challenge is not knowing what to do, but it's more how you do it. It's how you implement things that we know work. And so to give you some examples of that, there are some very simple things that can be done in care homes to prevent infection. We believe there's some evidence that improved hydration can prevent urinary tract infections. And there are some projects that have been done in care homes that suggest this is the case. But they're not evaluated in a research context, and so that means that we lack the evidence to really scale these interventions up and to have them adopted into policy. And there are also lots of concerns in this population about the unintended consequences of simple things like hydration. So we know there are high rates of incontinence in care homes, and so a real challenge is if you start hydrating people, they then need to use the toilet more frequently. That increases the risk of falls, for example. So nothing is straightforward in this setting, but there are lots of opportunities to do better on preventing infection. Probably the best example of a strategy to prevent infection is vaccinations. So we know vaccines work really well. The graph on the right here shows the rollout of vaccines in care homes in the COVID pandemic, and you can see the majority of people getting lots and lots of vaccine doses. And the graph on the left shows the mortality in care home residents, and what you can clearly see is the huge fall by Q2 in 2021. So in red, that's COVID-related deaths. And that just shows you once vaccines were in, the death rate in the care home population fell dramatically. So vaccines highly effective in this population. But what we also know is that getting people vaccinated is not always straightforward, and particularly for health and social care workers, there are all sorts of reasons why people are nervous about being vaccinated. And this is data on vaccine uptake for flu in healthcare workers in hospitals. We don't have equivalent data, to the best of my knowledge, in care homes, but you can see that we're really struggling to get very high rates of uptake, even though we know these vaccines are effective. And there are very good reasons for this. And I still find this quite astonishing. During the pandemic, social care workers were the only group for whom vaccination was actually mandated during the pandemic. There was talk about making vaccines mandatory for healthcare workers, but this never came to pass. And this was only a temporary thing, but it's still quite a dramatic approach to take where you lose your job if you're not vaccinated. And there are all sorts of barriers to vaccination, so things like fear about side effects, lack of trust, people feeling pressurized to be vaccinated, but then equally strategies that can be used to try and support vaccination. And these are the kinds of approaches that could have a real impact on reducing the amount of infection in people in care homes and consequently the amount of antimicrobial resistance. And so I just want to finish by mentioning a project that we've set up called the Vivaldi Social Care Project, which is really about trying to learn lessons from COVID and think about how we can tackle the problem of infection and antimicrobial resistance more effectively in care homes. And so here what we're doing is establishing a network of around 1,500 care homes for older adults in England, critically that's underpinned by linked electronic care records. And the idea is starting simply, so trying to be able to have reliable estimates of the amount of infection in patients in care home residents, but then also thinking about how we can use this network and data infrastructure to support the delivery of clinical trials so that we can start to try and get the evidence to support the rollout of things like vaccination and hydration to try and get better at preventing infection. And if any of you are interested, the link is there for a video that explains a bit about the study. So to conclude, I hope I've convinced you that we've got very different populations who are presenting with infections and antimicrobial resistance across primary care, secondary care and care homes. And consequently, the priority drivers and the issues related to antimicrobial resistance are not the same in each of those settings. In primary care, I would argue that the key priority has been about trying to reduce unnecessary exposure to antibiotics. For example, by using delayed prescribing as a strategy for low-risk patients so that only those people who really need antibiotics actually get them. In secondary care, the challenges are different because patients are sicker, and so here it's not necessarily safe to withhold antibiotics, and so the priority instead is to try and withdraw antibiotics in those patients who are started on them but subsequently seem to get better or to not have an infection at all. And the challenge is there about how you do that most effectively. In care homes where you have a very vulnerable population, it may not be appropriate to send people into hospital. The key is to prevent infections in the first place. But as I've explained, our challenge is how do we do that effectively? And we need to be able to do more research in this setting to work out the best approaches here. But then overall, I would say that probably with the exception of primary care, one of our real challenges is that it's hard to know the most effective things to do if you can't measure infections and prescribing and AMR across each of these settings. And what we really need is better data so that we can understand where we should be putting our efforts to try and minimize antimicrobial resistance. Sadly, this still remains a major challenge. So I've listed further reading for you here, and thank you for listening, and I hope it was interesting.